All right. Hey. Okay, just the recording in progress, just making sure that wasn't somebody else talking. Welcome, everybody. I appreciate your time and your being here. This little lecture series or video, or webinar, I suppose, is more accurate. I do record a lot of videos as part of my job as a professor, so I'm used to that. But we're talking about nutrition and mobility. In other words, the effects of aging on muscle health and dietary intake. If you're curious, this is my second year as an assistant professor here at UND. My PhD is actually from NDSU, so my education is North Dakota based. We don't talk about that though at UND. We don't talk about the NDSU connection, just shh. But we'll get going here. So thank you, folks. So as far as today's objectives, our first objective is to describe the importance of adequate nutrition in relation to strength and mobility with older adults. Then we're going to go through the specific nutritional requirements of older adults versus, well, younger adults. We're going to complete appropriate strength, nutritional, and food insecurity screening with older adults. Recognize the importance of referring this population to dietitians for individualized dietary counseling, and then apply, right, this sort of knowledge to a case study at the very end here. So just so we can get the wheels moving in our heads here, this is the case study that I'm talking about, and we're going to, I suppose, take a little bit of time to read it here. So I'm going to read it out loud just to make it a little bit easier for folks. And that way I know people have had the time to read it. So Mrs. Smith is a 70-year-old retired teacher who lives alone in a suburban community. She has a history of osteoarthritis in her knees, which limits her mobility and makes it difficult for her to engage in physical activities. Her husband passed away 5 years ago, and she's been living independently since then. Mrs. Smith enjoys cooking and gardening, but has recently been experiencing some challenges in maintaining a balanced diet and staying active due to her arthritis. Mrs. Smith's diet consists mainly of convenience foods and processed meals because she finds it challenging to stand for long periods to cook. She tends to skip meals or opt for quick snacks instead of proper meals. Her diet lacks variety and often lacks essential nutrients. Due to her limited mobility and reduced strength, she has experienced some unintentional weight loss over the past few months, which further exasperates her weakness and fatigue. She used to enjoy gardening, but now finds it difficult to kneel and bend due to joint pain. So folks, thank you for listening to me while I read that. Keep that in mind as we go on throughout this material in the webinar here today, because at the end, of course, we're going to be returning to this case study to get some of your feedback and to answer some questions and talk about some useful screening and clinical tools as well. So folks, getting into the nuts and bolts of this, not to state the obvious here, but muscle mass and strength declines as we get older. So this is pretty good data set from the Baltimore longitudinal study of aging, folks. And so we're looking at different decades, essentially, of aging, of periods in which people were measured. Arm strength is in the dark line. Of course, the dotted line is arm cross-sectional area. And then this, I should say, the dashed line is arm cross-sectional area. And the dotted line is creatine, which is a way of measuring somebody's muscle mass. It's deuterated creatine analysis, technically. The point I want to make, and something I'm sure we're all aware of, is that muscle strength and muscle mass, right, declines as we get older. Particularly at about age 70, right, we see a really big decrease in muscle strength, especially relative to measures of muscle mass. And this is important to us because older adults use close to their maximal muscle power just to stand from a chair. So this loss of muscle mass and strength is more than just, I don't know, people think like athletic performance. It's very much everyday performance, the type of activities that allow us to maintain our independence, such as, for instance, getting up to stand from a chair. So in light of that, or in tandem with that, you could say, sarcopenia is this age-associated loss of muscle mass and strength. It's actually a diagnostic criteria. We'll be talking about that near the end of this webinar, excuse me, but there is an ICD code. So there is a diagnostic code for sarcopenia back in 2016. Sarcopenia is defined first using low muscle strength, then low muscle quantity or quality, and then poor physical performance. So somebody with low muscle strength has probable sarcopenia. Somebody with low muscle strength and low muscle quantity has confirmed sarcopenia. And somebody with both low muscle strength, low muscle quantity, and poor physical performance has severe sarcopenia. And sarcopenia, if you're curious, this is a picture of somebody who's maintained physical activity as they've gotten older. This is a picture of someone's same leg, the upper leg that is, of someone who hasn't maintained physical activity, someone with sarcopenia. And so that's what we're seeing here is the decrease in muscle mass from one here on the right, essentially somebody with sarcopenia to somebody without. So it's a really big change, and it has big implications for our overall health. So sarcopenia, in simplest terms, why we care about it, number one, it increases our odds of mortality by 3.6 times, excuse me, not percent, but times. In addition to that, it increases our odds of disability by 3 times. So people with less muscle mass and strength are more likely to be disabled and more likely to experience early mortality. This is because amino acids in our muscle tissue function as an amino acid reservoir. So about 40 to 50% of our body weight is found in muscle tissue, providing about 45% of the body's total protein content. This means during periods of trauma or negative energy balance, the body will catabolize its own amino acid reservoirs to provide these essential amino acids for other tissues, typically, right, more important organ systems than our skeletal muscular system, right? So more important organs like our liver, for instance, compared to like a bicep. Nonetheless, right, because the catabolism of that muscle tissue eventually leads to, well, sarcopenia, that can increase our odds of disability and mortality because, well, there's less than an amino acid reservoir for our body to utilize in periods of trauma or negative energy balance. And this is reflected by quite a few different findings. So this is one of the projects that I worked on as a graduate student. It's a narrative review about the associations between hand grip strength, so how hard somebody can squeeze right, and a variety of different health factors. And we found that decreased hand grip strength was related to increased odds of diabetes, cardiovascular disease, impaired cognition, Alzheimer's disease, disability, and death. So again, these losses in muscle mass and strength that we see with aging are more concerning than just simply a decrease in somebody's ability to pick something up. They're related to a host of other comorbidities that are more serious than a decrease in muscle strength. So in light of the fact of the body's amino acid reservoir being protective against mortality, these are the classical U-shaped mortality curves that we see with BMI, looking at all-cause mortality, communicable diseases, non-communicable diseases, and injuries and external causes. And we see that with injuries and external causes, a flattening of the U-shape of the mortality curve at higher BMIs. And this is related to the amino acid functionality or the amino acid reservoir functionality of our body muscle. People with greater BMIs, although they might have greater body fat, odds are they also have greater body muscle. And so there is population level data to support the notion, right, that our bodies act, and specifically our muscle tissue acts as amino acid reservoir, again, during periods of either trauma or negative energy balance, which is not getting enough energy intake. So there are a few different factors that contribute to the age-associated loss of strength and power. We have changes in our muscle system themselves, nervous system changes, it's the neuromuscular system, right? Decreased hormones, particularly sex hormones, are important for muscle mass and strength. We have decreased activity and inactivity, or increased inactivity as we get older. Other comorbidities can affect muscle strength as well, of course, but we're here today to talk about, of course, nutrition and dietary intake. So unfortunately, as we get older, folks, our ability to eat tends to get worse. And this is also something I'm sure that as clinicians, you're probably well aware of. But a few different things happen. One, as we get older, our ability to taste gets worse. So does our oral health. People have increased amounts of dental caries, missing teeth, dental procedures, etc. And for these reasons, and among others, our ability to chew decreases. Combined, the net effect of these negative changes on oral health really drives dietary intake down by about a quarter from age 40 to age 70. And this actually predisposes older adults to nutrient deficiencies because in general, they're tending to eat less. Beyond that, energy expenditure can also decrease, or does in fact decrease as we get older. So older adults who maintain the same amount of dietary intake may actually gain fat because they're in a positive energy balance, resulting in a condition known as sarcopenic obesity, or essentially low skeletal muscle strength and mass coupled with, well, obesity, of course. There are a variety of different nutrients that are important for muscle health and health in general. In fact, we could go through them all, but of all the different nutrients, dietary protein is of most interest. Dietary protein can directly stimulate muscle protein synthesis. It does this by activating a really key molecular complex that really measures cellular energy levels. It's an integration pathway between essentially atrophy and growth, and that is the mammalian target of rapamycin complex 1. This is an amino acid sensitive protein complex that increases the amount of translation, the production of proteins from messenger RNAs in response to dietary protein. Generally speaking, there are 3 actual keys to dietary protein success. The first and probably most obvious one of these, is protein quantity, the actual amount of protein consumed. Well, there's bad news here, especially for us as we get older. This is data from younger and older men looking at the breakpoint analysis at which dietary protein maximized muscle protein synthesis rate. And we see that older adults, people in A and B versus those in C and D, have greater protein needs. So looking at the amount of protein needed per kilogram of body weight, older adults, really older men in this case, need 0.4 grams per kilogram per meal. Younger adults, really younger men in this instance, need 0.24 grams per kilogram per meal. And there's not a data set available on women comparing older women to younger women that I'm aware of. And so this is the best functioning data set that we have. Nonetheless, it really clearly indicates the fact that older adults quite literally have greater needs for dietary protein. They need more protein to maximally stimulate muscle protein synthesis. On top of that, to make things even worse, this is the anabolic response to exercise between younger adults and older adults. So younger adults are the solid line, the dashed line is of course the older adults. Well, we get less muscle protein synthesis following exercise in older adults compared to younger adults. So older adults get less of a response to muscle protein and less of a response to exercise, at least regarding muscle protein synthesis. This is really problematic as far as trying to increase or improve older adults' muscle strength and muscle mass. The good news is, especially from a dietitian or from a dietitian standpoint, is protein intake after exercise actually alleviates the differences between younger and older folks. So this is just a meal, and we're looking at elderly versus young versus meal plus resistance exercise. We don't see a difference between younger and elderly population in this study when they were comparing, right, the effects of a meal plus resistance exercise on muscle protein synthesis, even though a meal alone or exercise alone did have a lower effect as we got older. In other words, dietary protein again and resistance exercise had less of an effect on muscle protein synthesis in older adults compared to younger adults. And so again, though, we can get rid of that difference from this data, or the indication from this data is we can bridge or mitigate that difference by providing dietary protein after resistance exercise for older adults. So this means that dietary protein and of course also resistance exercise is critical for maintaining muscle mass and strength as we get older. So how much protein is enough protein? Well, the NIH recommends 0.8 grams per kilogram per day, but experts in aging and muscle health recommend more, either 1 to 1.2 grams per kilogram per day or 25 to 30 grams of protein per meal. That data set from, looking at breakpoint analysis of protein intake and muscle protein synthesis suggests older adults should be getting 0.4 grams per kilogram per meal. And if we're assuming 3 meals a day, that comes out to 1.2 grams per kilogram per day as a total. So that's a pretty accurate estimate right there. I would lean towards more 1.2, than 1 as far as the appropriate protein intake for older adults. Moving on from protein quantity, there's also protein distribution, which is a key factor for optimizing the body's response, specifically muscle protein synthesis to dietary protein. So these same studies that inform that 0.8 gram per kilogram per day recommendation only include works where the participants ate 3 or more isonutrient meals. These are meals where the dietary intake was completely standardized, meaning each meal was the same as the next meal. Now, you might be thinking this right now. Most people do not eat the same meal for breakfast, the same meal for lunch, and the same meal for dinner. So this is a limitation of these nitrogen balance studies. Breakpoint analysis, right, of the maximal amount of protein needed to stimulate muscle protein synthesis for older adults indicates a value greater than 0.8 grams per kilogram per day. So in addition to getting more protein intake, older adults should be spreading this out throughout their day. Well, as I was mentioning, this is something that folks in general struggle with. So this is part of the papers I published for my dissertation. This is looking at dietary protein intake distribution and markers of muscle health. This is specifically our participants' daily intake of protein at breakfast, lunch, and dinner. And folks, I'm not going to spend a ton of time on this slide, but I just want to note that at breakfast, people average 17 grams of protein, at lunch, 28 grams of protein, and at dinner, close to 40 grams of protein. So people do not eat in the same way that we have the NIH recommendation for protein intake. People do not eat the same amount of protein for breakfast, lunch, and dinner, which would optimize the body's response to that dietary protein, leading to gains in muscle mass and strength. And in fact, in my research and my dissertation, that's what we found. We found those getting the proper amount of protein intake at each meal was associated with increased amounts of lean body mass, increased maximal hand grip strength, increased summed lower body peak torque, so increased lower body strength, and increased lower body endurance. So protein distribution is also important to consider in our context of overall protein intake. Somebody who's getting all their protein at one meal is missing out on quite a lot of the benefits from that dietary protein, at least as it pertains to muscle mass and strength. The final one of these keys to protein success is, of course, protein quality. Protein quality is scored using something called the digestible indispensable amino acid score, which replaced the protein digestibility corrected amino acid score more than a decade ago. So we use the DS now, not the PDCAAS, and this is an objective way of scoring the amino acid content and digestion and absorption of various different dietary proteins. Proteins with values over 100 are complete proteins, between 99 to 75, good quality proteins, and below 75, poor quality proteins. The reason why I talk about this is we're in a kind of a big hype, right, with social media and a variety of other things. Well, let's take a look at the best sources of dietary protein. They are whey, egg, casein, and in this case, they investigated pork. All of these cases of dietary protein have values over 100. These are all from animal products. The plant products that have dietary protein values over 100 include soy and potato. The other plant products do not have dietary protein values over 100. So animal-based proteins do have better protein quality than plant-based proteins, and this is driven, in fact, by their better amino acid score. Animal proteins have greater essential amino acid content. Essential amino acids can't be produced by the body. They also tend to be more anabolic amino acids in general. Leucine, for instance, has its own sensor related to mTORC1 activation, increasing muscle protein synthesis. So we see after a breakfast either of cereal versus egg protein, when matched for protein and energy intake, that the egg protein breakfast in older adults led to more positive net protein balance than the cereal breakfast. So again, objectively, animal proteins are higher quality proteins, and they're more related to more positive net protein balances in older adults. Beyond dietary protein intake, we're going to take a transition here, folks, and away from protein now that we've talked about the final element of dietary protein, which is protein quality. We're going to focus on aging and inflammation. So there's probably somebody out there right now in the audience who's very, very familiar with the inflammation or inflam aging hypothesis of aging. But regardless of whether inflammation really causes what we see with aging or whether it's just associated with aging, it is really clear, right? As we get older, we have increased issues with inflammation. That's what's noted here on the table to the left, looking at some of these different markers of inflammation, like interleukins, for instance. So inflammation is at least partly regulated by our production of eicosanoid hormones that regulate specifically, well, inflammation. So eicosanoids are a class of autocrine or paracrine hormone. The omega-3 eicosanoids, or the eicosanoids produced from omega-3s, are going to have anti-inflammatory effects in the body, whereas the eicosanoids produced from omega-6 fatty acids are converted into pro-inflammatory hormones. So this means that our intake of omega-3 to omega-6 fatty acids also impacts our muscle health as we get older, through really augmenting inflammation in the body. This is an example of some of the different eicosanoid hormones, folks. Just so if you're curious, really they consist of the prostaglandins, the thromboxanes, the leukotrienes, and a couple of other different classes of hormones. In general, though, their effects are quite different regarding the omega-3 fatty acids and the omega-6 derived messengers from fatty acids. The omega-6 fatty acids are associated with things like inflammation and vasoconstriction. The omega-3 derived hormones, on the other hand, are associated with things like vasodilation and being anti-inflammatory. So in other words, right, to put it simply, we want to increase our intake of omega-3 fatty acids. Now, some people indicate that we should be decreasing our intake of omega-6s. That's really not the issue from a professional and a nutritionist standpoint. Really, the issue is low intake of omega-3s. These are largely found in fatty fish. And frankly, out in North Dakota, people do not eat enough fatty fish to provide substantial amounts of omega-3 fatty acids. So why do we care about omega-3 fatty acids and muscle health and mobility? Well, omega-3 supplementation, not avoiding omega-6s, folks, but just supplementing with omega-3s, improved muscle strength in older adults. Both those participating in resistance training, and those not participating in resistance training. So there is real firsthand evidence, right, that providing these is actually going to benefit people's function, potentially decreasing odds of sarcopenia, disability, and mortality. Beyond muscle strength, folks, turning our eyes to mortality, this is the intake of two different omega-3 fatty acids. And what we see is those with excuse me, a little indigestion there. Those in the greatest tertile, the highest tertile, the third tertile, the dashed line, had decreased rates of mortality versus those in the lowest quartile, the first tertile, the solid line. So beyond improving muscle strength, omega-3s, at least the composition of our fatty acids regarding omega-3s, is related to somebody's odds of mortality. So we care about omega-3 intake beyond muscle strength and mobility, but also for preventing the greatest outcome of health, which is, of course, mortality. All right, folks, I'm trying to hit all the hits here today. So we're going to move on from omega-3 to omega-6 fatty acids to another fat-soluble compound. In this case, it's cholecalciferol, or vitamin D. So vitamin D is something that's negatively affected by aging as well. Regarding the synthesis of vitamin D in our body, one of the few micronutrients that the body can produce on its own, the body can synthesize its own vitamin D from 7-dehydrocholesterol. However, our ability to do this decreases as we get older, simply because we produce less of this precursor, less of 7-dehydrocholesterol. Beyond that, regarding all vitamin D, whether it's produced endogenously or consumed exogenously, older adults have decreased expression of 1-hydroxylase. 1-hydroxylase adds a hydroxyl group to 25-hydroxycholecalciferol, forming 1,25-dihydroxycholecalciferol, which is also known as calcitriol, the active hormonal form of vitamin D that increases calcium absorption from our gut and decreases calcium output from our kidney. It increases calcium reabsorption, in other words. But the problem here is older adults actually have a harder time producing an active form of vitamin D, in addition to producing vitamin D in itself. So this is coupled with issues to bone health. Bone health is important for mobility as well. Our muscles, right, connect through tendons, that is, bone to bone, which allows for locomotion. Without having bone connected to our muscle, we would not really have an ability to move, right? So bone health is important for mobility as well. Now, bone health peaks, sometime when we're pretty young, maybe 20 to 30 years of age, stays relatively elevated till about 40. After about age 40, right, it's another case where aging is not good, not fun. We're going to see a decrease in bone mineral density. In addition to that, women are going to be at greater risk for negative health consequences of bone mineral density or decreased bone mineral density, because in general, they have lower peak bone mineral density than men. And because of the effects of, menopause on estrogen, they tend to lose more bone mineral density after menopause compared to men. So that's really nicely captured in this figure here, folks. So in general, right, we're much more concerned about osteopenia, osteoporosis in females compared to males, again, because males have more bone mineral density in the first place and lose less because they don't go through menopause. Well, unfortunately, vitamin D deficiency, which is related to bone health, probably most obviously, is also unfortunately related to decreased muscle strength. So if we have decreased amounts of vitamin D, we actually get decreased amounts of growth factors like insulin-like growth factor 1, which then activates things like protein kinase B, and then in turn eventually mTOR, leading to protein synthesis. We have decreased amounts of vitamin D, we have decreased amounts of this cascade, and we have decreased protein synthesis. In addition to that, we're going to have activation of the FOXO transcription box, leading to muscle atrophy as well. So vitamin D deficiency also drives decreases in muscle strength. And as we're getting older, right, we're producing less vitamin D. And what's notably pictured here, folks, is this is the active form of vitamin D, 1,25-dihydroxycholecalciferol, or calcitriol. So we're producing less of this active form of vitamin D as we're getting older, another factor for decreased protein synthesis and muscle atrophy. Well, just like looking at the omega-3 supplementation, folks, vitamin D supplementation. Now, this is just healthy individuals, not necessarily older adults, but it improves both upper and lower body strength. So this is another methodology and another reason or another nutrient that we can focus on for older adults, and an emphasis, again, to improve muscle strength and mobility. Now, the reason why I'm talking about vitamin D in this particular lecture is, well, in North Dakota, your odds of making vitamin D from sunlight are really, really bad. So if you're above the 37th degree latitude, which is what's pictured here on the slide, of course, the body can only make vitamin D from May to October. And because North Dakota is quite a long ways above the 37th degree parallel, which includes pretty much all of Colorado, I bet, folks, and I was trying to find this data, but I couldn't find it, I bet you our period is even shorter than May to October. Maybe it's June to September. So you have to be outside during that period of the year to actually get vitamin D from sunlight. If you're outside in January, folks, even if the sun's shining, you're not making vitamin D. If you're outside today, it's a beautiful day out today, the sun's not at a high enough angle, you're not going to be making vitamin D. So this is a really big issue this far north, where we have a really limited time of the year to produce vitamin D endogenously from sunlight. Beyond that, folks, increased exposure to sunlight increases our odds of developing melanoma. On top of that, you have to be outside during the middle of the day to get this sort of sun exposure. So like, not only do you need to be outside from May to October, but you need to be outside from May to October at like noon, like right when we're talking right now, for instance. Beyond that, depending on your skin, you might actually produce more or less vitamin D as well. So melanin, the pigment in our skin, absorbs ultraviolet B light, which is responsible for forming vitamin D in our skin. So if you have darker skin, these people actually need longer or more sun exposure to make the same amount of vitamin D. So if you have darker skin and you live in North Dakota, you're at even greater risk for this sort of a deficiency. As I mentioned, as we get older, we make less vitamin D too. And then finally, right, the real big kicker is above the 30 degrees of the horizon, we're not making vitamin D anyway. So most of the year, we're not doing it. Point being is making vitamin D from sunlight has a lot of practical limitations. it's not really a viable way of achieving, for most people at least, optimal vitamin D levels or intake. We're going to wrap up there with vitamin D, and we're going to move on now to the final nutrient I'll be talking about in my complex. And this is the fourth one, the vitamin B12 or cobalamin, and its association with aging as well. So a deficiency of cobalamin or folate, because they're involved in the same cycle, the methionine folate cycle, results in pernicious or megaloblastic anemia, right? So anemia characterized by few really large red blood cells with a high mean corpuscular volume. But more important for our conversation today would be cognitive impairment and frailty. B12 can be problematic, right, if we're not getting enough of it for older adults. The issue is, just like vitamin D, although with vitamin D, it's converting it to its active form, as we get older, we actually literally absorb less vitamin B12. This is because as we get older, we reduce our production of stomach acid. We need our stomach acid to actually free vitamin B12 from other foods and allow it to be absorbed by the body. The vitamin B12 we're going to be eating is probably going to be bound to an animal protein, folks, and we need that hydrochloric acid in our stomach to denature these proteins and result in vitamin B12 that can be absorbable. So not only as we get older, we produce less stomach acid just naturally, a lot of older adults are also prescribed, proton pump inhibitors, or might just use over-the-counter heartburn medications like, I don't know, Maalox or something like that. Well, all of those also limit our ability to digest and therefore absorb vitamin B12, even putting older adults at greater risk of a B12 deficiency. So folks, this is a Japanese study looking at the B12, essentially B12 insufficiency on muscle strength, muscle mass, and physical performance, the criteria we utilize for diagnosing sarcopenia. And although they didn't find an association between low amounts of B12 and muscle strength or physical performance, they did see a strong correlation with low appendicular skeletal muscle mass. So there is a relationship here between B12 deficiency and not having proper muscle health, specifically muscle mass. This, folks, is all complicated by the fact that older adults actually burn less energy doing literally the same activity. So even when controlling for lean mass, like muscle mass, older adults actually burn less energy as we get older. From a nutritional standpoint, this means older adults need less energy intake. Generally speaking, unless somebody's goal is to gain or lose body mass, we're trying to keep people in energy balance, meaning their energy intake equals their energy output. So if older adults are burning less energy, they actually need to intake less energy, therefore, which means, generally speaking, less food. However, older adults have increased intakes of the nutrients that I just discussed today. Protein due to anabolic resistance from both dietary protein and resistance training. Calcium, which I didn't talk about today, but that's related to vitamin D. I actually meant to switch calcium. Shoot, folks. But calcium as well due to decreased absorption related to vitamin D. But vitamin D is a bigger one. We need vitamin D, right, because we're decreasing the synthesis both from sunlight, but also the active version of vitamin D. And older adults need more vitamin B12 to counteract decreases in stomach acid production. The aspect that I meant to have here instead of calcium was, of course, omega-3 fatty acids. Older adults also need more omega-3 fatty acids. The issue here fundamentally, though, is older adults need more nutrients, more protein, more D, more vitamin B12, more omega-3 fatty acids for less total calories. So this means older adults really need to focus on nutrient-dense foods, consuming foods that provide a lot of nutrients, but relatively few calories. Well, to complicate this, folks, and I brought this up way back at the beginning of our webinar here, but to complicate this notion, our ability to taste gets worse as we get older. So this is a cross-sectional study looking at different age groups of subjects. We have our young adults aged 18 to 36, our middle-aged adults 37 to 50, and our older adults 51 to 80. We have 5 different tastes on the bottom. There were folks, on a side note, 5 tastes until recently in October of 2023, they discovered a 6th taste. So woot, woot, woot to the 6th taste, but the 6th taste is not pictured here on this table. Rather bitter, sweet, salty, sour, and savory are pictured. And we can pretty plainly see that as we get older, our ability to taste all of these gets worse. In addition to that, there's sex differences as well, where men tend to taste worse relative to women. Well, folks, the issue here is our perception of taste decreases as we get older, which means older adults prefer food that tastes stronger. Well, this leads to notably the intake or excessive intake of 2 things that are problematic. For our conversation here today about empty calories, the problematic one would be excessive sugar intake. Added sugar provides no other nutrients than just energy. It is by definition literally an empty calorie. So because older adults prefer food that tastes stronger because they literally taste worse, they tend to add sugar to foods that, generally speaking, younger populations would not add sugar to, again, thus increasing their energy intake of empty calories, which does not benefit the nutrients that they need to be consuming to properly upkeep or maintain muscle mass and strength. In addition to that, not a topic of today's webinar, but this also leads to excessive sodium intake, a risk factor for hypertension or high blood pressure as well. So that pretty much wraps things up before we move on to our case study here. We're going to have a couple summary slides before we get into it. But basically, one of our big points here today is that aging results in a loss of muscle mass and strength. And that loss of muscle mass and strength is a risk factor for disability, mortality, cognitive impairment, cardiovascular disease, and diabetes. These are not things that just stand alone, folks. Muscle mass and strength are related to a host of negative health outcomes. Specifically, I should say decreases in muscle mass and strength are related to a host of negative health outcomes. So beyond the fact that our muscle health gets worse as we age, our dietary intake also decreases as a result of aging, typically due to decreased oral health and lessened ability to taste. However, older adults still need greater intake of protein, omega-3s, vitamin D, vitamin B12. And actually, folks, I talked about calcium earlier, but there are other nutrients in addition to calcium that I could have went on and on about. I'm passionate about this subject that our older adults also arguably need more of. Calcium is certainly one of them. That's related to decreased ability of the body to produce the active form of vitamin D. Looking at these specific reasons why we need more of these 4 during aging, protein, older adults need more protein due to anabolic resistance to both exercise and to intaking dietary protein. Older adults need more omega-3 fatty acids due to increased inflammation that we see associated with aging. Older adults need more vitamin D because 1, we produce less vitamin D from sunlight, and 2, the more important one, we produce less of the active form of vitamin D because older adults have less of the enzyme 1-hydroxylase. Vitamin B12, older adults also need more of because of decreased absorption, because older adults produce less stomach acid, which is critical for freeing vitamin B12 as a coenzyme from the dietary proteins that it's associated with. So older adults need this increased nutrient intake, but they actually require decreased energy needs because as we get older, even if we keep our activity the same, our activity levels remain unchanged, which is usually not the case as folks get older. But even if those activities remain unchanged, older adults are literally burning less energy than younger adults, meaning they need more nutrient-dense foods. The issue here is that worsened taste in particular increases added sugar intake, which is an empty calorie. So older adults need to focus on consuming nutrient-dense foods. Nutrient density would equal the nutrient divided by the amount of energy or the amount of calories in that particular food. And that, folks, wraps things up as far as I suppose, the webinar aspect of this here today. We're going to move on now to our case application. I guess I'm going to read this again just so everybody has a refresher. Hopefully it's not too boring, but Mrs. Smith is a 70-year-old retired teacher who lives alone in a suburban community. She has a history of osteoarthritis in her knees, which limits her mobility, makes it difficult to engage in physical activities. Her husband passed away 5 years ago, and she's been living independently since then. Mrs. Smith enjoys cooking and gardening, but has recently been experiencing some challenges maintaining a balanced diet and staying active due to her arthritis. Mrs. Smith's diet consists mainly of convenience foods and processed meals because she finds it challenging to stand for long periods to cook. She tends to skip meals or opt for quick snacks instead of proper meals. Her diet lacks variety and often lacks essential nutrients. Due to her limited mobility and reduced strength, she has experienced some unintentional weight loss over the past few months, which further exasperates her weakness and fatigue. She used to enjoy gardening, but now finds it difficult to kneel and bend due to joint pain. So, folks, I don't know if people want to put it up in the chat or if you just want to, unmute yourself and call some things out. But what are some key nutrition and mobility factors from the case example? You can take your time here. I know it's a little bit of a rush, and I tend to talk pretty fast. Okay, well, I guess we're gonna just get going here and take some of these out. But convenience and processed foods, yep, there we go. Thank you. Excessive sodium intake. Yeah, processed foods definitely lack nutrients. That should be the big one. And then we know what also processed foods tend to have is a lot of empty calories. In fact, that tends to be one of the few things that these processed foods really do provide a lot of, in addition to sodium, of course. Lack of essential nutrients. This goes hand in hand, honestly, with the processed foods, like what people were saying. Maybell here, really good comment, which lack proper nutrition. Yeah, these foods, processed foods in general, don't provide the nutrients that the body needs, but they're cheap and convenient, which is why people buy them, of course. Oh, and they taste delicious as well. Unintentional weight loss should be a big red flag for us for older adults. Now, it varies, right? And I'm not trying to give broad recommendations for literally every person, but generally speaking, in most older adults who are a healthy weight, I wouldn't want to see weight loss. Weight loss could be an indication of something bad. And in particular, right, if that older adult's losing lean tissue, that's going to be really devastating. So unintentional weight loss should be something that we're always aware of, particularly with older adults. And for me, it should be an instant red flag. Older adults should not be experiencing unintentional weight loss. Limited standing endurance / tolerance. Oh, yeah, great post there, Aaron. Yeah, wondering if she qualifies for Meals on Wheels. That would be a great way to go. Limited standing endurance tolerance for cooking is a big risk factor that plays in, right, to her choice for processed food. If you have a hard time cooking, right, it's easier to choose things that are already made, of course. I mean, I suppose that's a really obvious point. She's able to garden less, so she's probably producing less of those healthy foods. And then also, like, living alone, it's just hard to cook for yourself. So, I mean, like the last time I lived alone, I was in college, so it's kind of hard to like suss out the differences there. Let's just say lots of ramen, right? And I'm pretty sure other people who have lived alone are familiar with that. You tend to make cheaper, less nutritious, more convenient choices when you're just cooking for yourself compared to cooking for other people, right? When you cook for other people, you tend to put in a little more effort, a little bit more love, if you will, a little bit less of that when you're alone. All right, question 2. Aaron was on top of this one, but what screening assessments should be completed within the interdisciplinary team? So perhaps think about your role as a clinician or healthcare provider and think, what would you do or what would you recommend for Mrs. Smith? All right, I'm going to start going through them. Well, one of the things that we would recommend is the sarcopenia questionnaire, the SARC-F, which denotes whether somebody might be at risk, of course, for sarcopenia. We'd recommend a grip strength assessment. We had a good comment in here. Make sure she's seeing her dentist regularly. Yes, oral health is really important for these folks. I don't even think we have that on our list, so good catch there. Grip strength chair stand test is another measure of physical performance. That's just getting somebody to stand from a chair 5 times. Gait speed is a walking test. You time somebody walking a 6-meter course. Higher gait speeds and denoting a slower speed are related to increased odds like sarcopenia and disability. We can do the short physical performance battery. This is a test of balance and physical performance as well. We could do a DEXA to measure muscle quantity. That's dual X-ray absorptiometry. We could also use bioelectrical impedance if that's available to us. Regarding nutrition screening, we should be doing either the mini nutrition assessment, the MNA, or the the simplified nutritional appetite questionnaire, the SNAC. There's other questionnaires as well, but screening for malnutrition would be really important as well. I shouldn't say malnutrition, and suboptimal dietary intake might be more accurate. And then food security is a big factor as well. We can't make the assumption that older adults necessarily are getting enough of the foods that they want in the proper amounts. I want to just move on though, unless somebody has something they want to add to the chat quick here. Anyways, moving on, this is something that I would like to see a lot more done in clinical practice. This is the sarcopenia diagnostic protocol proposed by the European Working Group on Sarcopenia. Now, they proposed this setup, the find, assess, confirm, and then severity. I've worked with a lot of folks who just start with assess, but basically they use the SARC-F or clinical suspicion to then measure muscle strength using usually grip strength. If grip strength is low, sarcopenia is probable. This denotes that this should be confirmed with a test of muscle quantity or quality, such as DEXA, bioelectrical impedance, computed tomography, or MRI, and then finally followed up with a measure of physical performance. And if this is low, a person has severe sarcopenia. And the reason why we should be doing this as well, there is a diagnostic code for sarcopenia. Those who have the condition should be aware of its risks and ways that they can mitigate its harmful effects, namely, probably increasing physical activity, increasing dietary protein likely, perhaps increasing or taking a vitamin D or omega-3 supplement, and so on, right? So this is a fundamental protocol that I would like to see utilized by more clinicians. And what I'm suggesting is we could probably start with just muscle strength. I'm not sure we really need to do the SARC-F or the clinical suspicion. We could just start with do a hand grip strength test. A hand grip strength can be done sitting down and usually is low stress on most people. So it should be appropriate for the vast majority of patients or clients. So these are the cutoffs, folks, just so I'm not giving no sort of knowledge. These are the cutoffs that are recommended for these. So grip strength less than 27 kilograms in men or males, less than 16 for females. Regarding low muscle quantity, this is appendicular skeletal mass, so less than 20 for males, less than 15 for women. Or if we're doing, mass to height, it'd be 7 kilograms per square meter or 5.5 kilograms per square meter. And then low muscle performance, either really slow gait speed, poor short physical performance battery score, long timed up and go test, or long 400-meter walk. So my recommendation is, if you're a clinician, you buy a little hand grip strength dynamometer. The Jamar handheld dynamometer are like, I don't know, $200, $300 are not horribly expensive, especially in the realm of clinical equipment. You can then screen your patients for low muscle strength, which then could be followed up, if it is low, with screening for low muscle quantity or quality, allowing then for a diagnosis of sarcopenia. Dietary intake, these are both looking for at the chances of essentially malnutrition. They're not diagnostic tools, they're screeners, but the mini nutrition assessment is one of them. Those less than or the value equal to or less than 7 on this screener would be at risk for malnutrition. Specifically, they'd be considered, I guess, malnourished according to this. Those with the score of 8 to 11 would be at risk of malnutrition. So the mini nutrition assessment's a useful tool. As you can tell, there's not a ton of scoring that needs to be done. So it's a pretty straightforward process. It's one page. It's, I don't think, overly, what's the right word? Doesn't take us a ton of time to do it. I'm not going to think of the word right now. I apologize. So there's the M&A and there's also the snack. The snack asks people my appetite, when I eat, food tastes, and normally I eat, rated on scales from 1 to 5. Those with a score equal to or less than 15 on these questions are at risk for malnutrition, at least in community dwelling older adults. So these are good screeners looking for, well, is dietary intake to blame for these people's potential sarcopenia, right? And if it is, right, this would be a really clear referral to get someone to go see a dietitian. Finally, when we're talking about questionnaires here, folks, we have the USDA Food Security Questionnaire. This looks at, of course, well, food security. The short version has 6 total questions. Those with a score of 5 to 6 have very low food security or essentially have high food insecurity. Those with values of 2 to 4 have low food security. One of the things I want to note here is in the phraseology of these questions, balanced meals, folks. It's not just saying like, did you have food? Plenty of people can have some food, but actually balanced, nutritious meals. So that's one of the big components here of the food security questionnaire. People do not have access to balanced nutrition. They are food insecure, okay? And one of the things I want to point out is just because somebody comes into your clinic or the doctor's office, or they're in your long-term care facility, or they're at your school, whatever it may be, you don't necessarily know at face value whether somebody's dealing with food security or not. So it's good to just screen for it. It's a 6-item questionnaire. And if somebody has food insecurity, then you can refer them to other things like Meals on Wheels, for instance, and other programs too that might be helpful for them in the local community. We have quite a few good resources here, at least in the Grand Forks area. And so that is nice regarding food security. So on that note, I kind of got a little ahead of myself. What would be some appropriate referrals that you're thinking of as clinicians? I'm going to say Meals on Wheels, huh? Meals on Wheels should come to mind right away. That's one of the ones that I think of. There's a variety of other things, at least locally here, and hopefully where you're at in North Dakota. Nutrition, occupational therapy, physical therapy, great idea. Dietitian, love it. Dentist too. Dentist was earlier, but I like dentist. Labs, yes. She's not getting enough dietary intake. Food banks, good. So one of the things that we haven't gotten to yet, and I just have bullet points coming up on up here, so you'll have to deal with them not being in exactly the most conversational order, but NDSU Extension Service, who I do some work with over there as well, they have some pretty good resources. So one is the Nourish Your Body program. This is meant for older adults. It's a series of nutrition lessons designed to teach older adults about the importance, especially of dietary intake, as they get older. The Cooking for 1 or 2 program is just as it sounds. It's a program with emphasizes recipes and affordable ways to cook easy, simple meals for 1 or 2 people. So really great free to use programs by NDSU Extension. So thank you. It's always great. I do a lot of work with Extension as well. But dietitian for an individualized plan is absolutely going to be necessary here. I mean, that is just key whenever you're dealing with somebody who has suspected malnutrition. They should be absolutely seeing the dietitian. Occupational therapy, great idea, right? We want to help with especially meal prep. In the chat here, I have a comment from Mabel. that, we can do prep sitting and transfer food over with a walker. There's a lot of things that the OT can help with as far as making cooking being a more enjoyable and easy process. And not just cooking, right? Maybe gardening too, some of those other activities that she used to enjoy. Physical therapy for muscle strengthening and help manage some of that osteoarthritis. Now, in light kind of the food bank discussion, we didn't say food bank, we said social worker. Social worker can help refer people to other resources they might not be aware of, like the food bank, which I think would fit nicely here in this bullet point. So food bank, definitely. And then probably, depending on who you are, right? If you are the physician, this doesn't need to be you. But if you're not the physician, this might need to be you. You might need to refer the person to a medical doctor to get a diagnosis or to get additional screening for things like a DEXA, right? So if you expect, or excuse me, not expect, but suspect something like sarcopenia, maybe you can't diagnose it in your clinical role, but you could write a note to the doctor saying, so-and-so has decreased hand grip strength. Can you put in a referral to do a DEXA or to do some other sort of imaging to confirm the sarcopenia? And that's it, folks. I'm kind of trying to finish up right at 1, and I think I've just about nailed it. If you have any questions, please email me. Please note the 4 in my email. I am Nate Johnson here at North Dakota. There's a lot of Nate Johnsons. I'm number 4. So remember to email number 4, not the other Nate Johnsons. It's not going to help you. And then beyond that, folks, I got references if you want to see references. But any questions?
Well, with that, and that was a great presentation, Nate, and I will be sending out a follow-up email that will have the PowerPoint again, so you'll have the emails in there too, as well as a link to the evaluation in case you didn't have a chance to complete that today. But thank you so much for the great presentation.
Thank you, folks. Yeah, don't be shy. Come say hi to me.
Some comments coming in saying thank you. It was great. So. All right, well, we will sign off there and then look for that email and certainly reach out if you have questions directly.
Thank you, everybody.
Thank you.